Welcome to my channel. In this video, I will discuss Human Immunodeficiency Virus (HIV). In this video, I will discuss its clinical features, how it is diagnosed, how it is managed, and HIV in pregnancy. So, it is a retrovirus that attacks your CD4 helper T cells, leading to progressive immune system failure. Because these CD4 helper T cells are responsible for production of certain cytokines that activate the other cells. Transmission. It can be transmitted mostly through unprotected sexual intercourse, but can also be transmitted through blood transfusion and needle sharing, and also it can be transmitted from mother to child, especially during birth. HIV structure and pathogenesis. The virus is a retrovirus. It means it is having RNA, then its RNA is converted into DNA by reverse transcriptase. Key enzymes are reverse transcriptase, integrase, and protease. This reverse transcriptase converts its RNA into DNA. Integrase integrates this DNA inside the human DNA, and protease then cleaves and produces the viral copies and release this towards the other cells. Target cell. CD4 positive T cells are the target cells. Macrophages can also be affected initially, and dendritic cells are also affected initially. Pathogenesis. First, virus enters into your bloodstream through the mucosal surfaces or directly through the bloodstream. It binds to your CD4 receptor and also other co-receptors. These are CCR5 and CXCR4. These are co-receptors. Then it integrates its viral DNA into the host genome. After this integration, there is production of the new HIV copies that lead to gradual destruction of CD4 positive cells and then are ready to attack other cells, leading to immunodeficiency because your CD4 positive cells are burst when the virus leaves the cells. Natural course of HIV infection. First one is acute HIV infection. In acute HIV infection, mostly patients are asymptomatic. Clinical latent phase, second phase. Third phase is non-AIDS defining illnesses, and fourth phase is AIDS defining illnesses. So we will discuss now in detail. Acute HIV infection, that is primary stage. It has 2 to 6 weeks of duration after exposure, and the features are fever, fatigue, non-tender generalized lymphadenopathy. Your lymph nodes are swollen. Maculopapular rash appear that is generalized, may be present all over the body. You may have oropharyngeal features like sore throat, oral ulcerations. Patient may have myalgia and arthralgia and diarrhea. So, patient has fever, fatigue, lymphadenopathy, generalized rash, sore throat, myalgias and arthralgias, and diarrhea in acute retroviral illness. Now, in acute illness, you will detect that the viral load is quite high. Then the next phase is clinical latent phase. Its duration is 2 to 10 years and it is asymptomatic period. Its features are patients may appear healthy. There may be persistent generalized lymphadenopathy. There is slow decline in CD4 count because viruses when leave the CD4 cells, then these cells are burst. And there is ongoing viral replication inside your lymph nodes. So lymph nodes are the sites where the virus replicates in latent phase. Next phase is non-AIDS defining illnesses. That is, these can occur in immunocompromised individuals also. When CD4 count is usually less than 500, then these illnesses start to appear. For example, oral candidiasis, oral thrush, oral hairy leukoplakia. It means that the Epstein-Barr virus infection causes oral hairy leukoplakia, and in this case the leukoplakia is present on the sides of the tongue and it cannot be removed from the tongue. Then herpes zoster, shingles reactivation, seborrheic dermatitis and recurrent bacterial infections, weight loss and chronic diarrhea. Also there is swelling of the lymph nodes. So lymph nodes are also swollen in all over the body. So these are non-AIDS defining illnesses that cause oral candidiasis, oral hairy leukoplakia, herpes zoster, shingles, seborrheic dermatitis, recurrent bacterial infections, weight loss and chronic diarrhea. Then AIDS defining illnesses. AIDS defining illnesses mostly appear when the CD4 count is less than 200 cells per millimeter cube. It means if you develop these illnesses, then you should suspect highly that you may have AIDS. Key conditions. First one is pneumocystis jirovecii pneumonia. Pneumocystis jirovecii pneumonia occurs when CD4 count is less than 200 cells per millimeter cube. So pneumocystis jirovecii pneumonia occurs when your CD4 count is less than 200. Tuberculosis extrapulmonary. It occurs when the CD4 count is less than 500 per millimeter cube. Kaposi sarcoma. It also occurs when your cell count is less than 500 per millimeter cube. Then CNS toxoplasmosis. It occurs when your cell count is less than 100 per millimeter cube. Then cryptococcal meningitis. It also occurs when your cell count is less than 100 per millimeter cube. Then we come to life-threatening infections like cytomegalovirus. It occurs when your cell count is less than 50 per millimeter cube. And non-Hodgkin lymphoma occurs when your cell count is less than 100 per millimeter cube. Also MAC infections, Mycobacterium avium intracellular infections occur when your cell count is CD4 count is less than 50 per millimeter cube. So these two infections, MAC and cytomegalovirus retinitis, occur when your cell count is less than 50 per millimeter cube. So first one is pneumocystis jirovecii pneumonia less than 200 per millimeter cube when cell count is. Tuberculosis less than 500 per millimeter cube CD4 count. Kaposi sarcoma less than 500 per millimeter cube. CNS toxoplasmosis less than 100 cells per millimeter cube CD4 cells. Cryptococcal meningitis less than 100 cells per millimeter cube. Less than 100 cells per millimeter cube. Cytomegalovirus less than 50. Non-Hodgkin lymphoma less than 100 and MAC less than 50 cells per millimeter cube. Now, how will you diagnose HIV? You have to go for screening tests. The most important screening test is antigen antibody immunoassay. Antigen antibody immunoassay. This test detects P24 antigen plus IgM or IgG antibodies against HIV. So this test P24 plus IgM plus IgG detection is the first test, and if it is positive it means you can have infection. Then other rapid antibody tests are also available. Then if you are having positive screening test, then confirmatory test should be done. Confirmatory test is mostly we do is HIV1 and HIV2 differentiation immunoassay, because screening test cannot differentiate this HIV1 from HIV2. So we go for HIV1 and HIV2 differentiation immunoassay. For early detection, we should only detect P24 antigen test, or we go for HIV RNA PCR, that is viral load test, because in the acute infection PCR shows high viral load. Also in the newborn you should do only HIV PCR, because in case of newborn he already has antibodies transferred from the mother to the newborn, and therefore if you are doing screening test then it may be false positive. So for newborn PCR, for early detection PCR viral load test. Then monitoring. For monitoring, you have to monitor CD4 count because this is important. If CD4 counts are less, you have a lot of chances of getting an opportunistic infection. Also, HIV viral load is important in monitoring the patient who has AIDS. Management principles. For management, whatever the stage of the HIV, whatever the phase of the HIV, you have to start antiretroviral therapy. For antiretroviral therapy, you have to give combination therapy of equal to or more than 3 drugs from equal to or more than 2 classes. Mostly we give 2 NRTIs, 2 NRTIs plus either 1 NNRTI, either 1 NNRTI or 2 NRTIs plus 1 protease inhibitor. NRTIs means nucleoside analog reverse transcriptase inhibitor. Goal. Main goal is suppress viral load to undetectable levels so that it cannot be transmitted to others, and also increase the CD4 count so that opportunistic infections should be decreased. Drug classes. First one is NRTIs, nucleoside analog reverse transcriptase inhibitors. These include tenofovir, lamivudine, zidovudine, emtricitabine, stavudine, didenosine. This didenosine is associated with acute pancreatitis, while this zidovudine is associated with heart failure, cardiomyopathy. But this zidovudine is very important when you are prescribing to a pregnant patient, because zidovudine is first line when the patient is pregnant and has HIV. So these are NRTIs. Then NNRTIs. NNRTIs include efavirenz and nevirapine. NNRTIs means non-nucleoside reverse transcriptase inhibitors. Then we have protease inhibitors. For example, lopinavir. Protease inhibitors are used in combination with 2 NRTIs, or NNRTIs are also used in combination with NRTIs. Integrase inhibitors, for example, dolutegravir, can also be used in combination. Third one, aim is adherence. Adherence should be critical because non-compliance leads to drug resistance in the patients who are not adherent to their antiretroviral therapy. So how we give this treatment? You have to give 2 NRTIs. For example, tenofovir plus emtricitabine. These are 2 NRTIs that should be given along with either 1 NNRTI, for example efavirenz, or either 1 protease inhibitor, lopinavir, or integrase inhibitor, for example dolutegravir. So 2 NRTIs should be given along with one of these agents. Adherence is critical. Non-compliance leads to drug resistance, as I have told you. Now, when you develop opportunistic infections, then for opportunistic infections you have to treat. But if you are having low CD4 count and you suspect that you can acquire these opportunistic infections, then you should go for prophylaxis. CD4 count is when less than 200, it means there is a risk of pneumocystis jirovecii pneumonia, so you should start trimethoprim sulfamethoxazole. If CD4 count is less than 100, it means you need prophylaxis for toxoplasmosis. Also for toxoplasmosis, you have to give trimethoprim sulfamethoxazole DS tablet. If CD4 count is less than 50, you should give azithromycin 1200 milligram orally once weekly for Mycobacterium avium complex prophylaxis. If the patient is in an area where coccidioidomycosis is suspected, so for coccidioidomycosis, if cell count is less than 250, then you should give fluconazole for prophylaxis for coccidioidomycosis. Then HIV and pregnancy. In HIV, the transmission risk from mother to the fetus is 15 to 45%, and for this purpose you have to avoid this transmission, especially at the time of delivery. So four factors are mainly important for the decreasing of the transmission risk. First one is cesarean section, cesarean section. Second one is antiretroviral therapy for mother. Third one is antiretroviral therapy prophylactically for newborn. And fourth one is avoid breastfeeding. So these four factors decrease the risk of transmission from the mother to the newborn. So for all HIV pregnant women, you should start ART immediately. Only efavirenz is a drug. Efavirenz is a drug that is contraindicated in HIV. Preferred regimen is tenofovir plus lamivudine plus dolutegravir. You can see 2 NRTIs plus 1 integrase inhibitor. Delivery, as I have told you, vaginal delivery is only done if viral load is undetectable, and C-section is done if viral load is high, because C-section prevents the exposure of the fetus from the mother. Breastfeeding, it is contraindicated when the mother has HIV. For neonate, when the neonate borns, give prophylactic antiretroviral therapy, nevirapine or zidovudine, so that the neonate can be protected from transmission of the HIV, and this is given for 4 weeks. Monitoring and follow-up is also required after 3 months, so that if seroconversion is present, it can be treated at time. CD4 count should be checked every 3 to 6 months for neonate. Viral load every 3 to 6 months, and should also screen for TB, hepatitis B and C, and cervical cancer. Prevention, safe sex practices, condoms, and post-exposure prophylaxis. Safe blood transfusion and needle use. Antiretroviral therapy for all HIV positive individuals. Routine screening for high-risk groups. Summary, HIV is a chronic manageable disease with early diagnosis and starting of the antiretroviral therapy. It has acute stage, latent stage, non-AIDS defining illness, and AIDS defining illness. Antiretroviral therapy drastically improves your life expectancy because it reduces the opportunistic infections. Early intervention in pregnancy prevents vertical transmission, because vertical transmission is also a major source of transmission of AIDS. So early intervention in pregnancy prevents vertical transmission, as I have told you 4 factors which reduce this transmission during pregnancy from mother to child. So this is all about AIDS.